Yeah. Hi there, it's Mark Fulcher here, and I'm joined tonight by Simon Young. We are coming to you from our living rooms, and we're hoping to talk to you about the examination of the knee via telehealth. So I can see that we've got about 100 participants. We're expecting about 400 participants, so we might just wait a few minutes while we're waiting for people to join us. For those of you that tried my webinar last week about how to run a telehealth conversation, there was lots of good feedback, and the feedback basically was, can you do some more? So this is our second one. This is on examining the knee. Tomorrow we're going to have Dan Exeter join us talking about medication and some of the impacts that the coronavirus and the shutdown might have on prescribing, particularly analgesics. On Wednesday, we're going to have Stephen Wood join us from Auckland Radiology Group to talk about radiology and some of the challenges or considerations around ordering imaging. And on Thursday, we've got Simon Grigger from a marketing company called Volum. Obviously, there's been a big change to the practicing environment for most of us in the physiotherapy, sports medicine, musculoskeletal landscape. And he's going to talk to us maybe about how to get the word out about our changing practice and to try and get clients to still come and see us and explain to them that we are a good option still. And then on Friday, if there's interest, we thought we might run a wrap-up of the week of telehealth. So I think for many of us, this is our first week where we've really spent a lot of time operating by telehealth, and we thought that maybe there'd be some learnings from the week and some things that we could share as a group. So the first 4 webinars are all at 8 o'clock, so Monday, Tuesday, Wednesday, Thursday. And then on Friday, I think a 1 o'clock webinar with me. So I can see that we've got quite a good audience, so I might hand over to Simon at the moment. So Simon Young is an orthopaedic surgeon that works at Axis on the North Shore, also works at North Shore Hospital. So I'm sure it's an interesting time for him at the hospital, but he has a subspecialty interest in the knee, and I feel like I've probably talked too much, Simon, so I'm going to hand over to you and let you talk about the knee.
So thanks, Mark, and thanks everyone for joining. So I'm going to try and talk about how to assess the knee on a telehealth consult, and this is fairly new to me, as it is, I'm sure, to most of you. So I'll sort of talk about my experience on what I've done in just the last week of doing this, and what I think are key points that you need to do when you're trying to assess a knee over telehealth. And in particular, I want to talk about the acute knee and what perhaps you might want to make sure you don't miss, because I think in this area of telehealth where you can't physically examine the knee, and we're all sort of learning how to do telehealth well, you want to, as you're getting into it, make sure you're not going to miss anything or make any mistakes early on. So that's kind of be the focus of the talk, of assessing the acute knee and what you need to look out for. So I'm going to switch over now to some slides, and hopefully this sharing the screen will work. And Mark, I hope that's all going through there.
Looks perfect at my end. So anyone, if there's problems, I know I screwed this up last time, so I'm sure someone will let us know pretty quickly if we haven't got that right.
So it's assessing the knee via telehealth, and rather than sort of talking about all the potential things that diagnoses that you might need to look out for, rather I'm going to think about what you're going to do. What are the boxes that you're going to put into, and particularly when you're assessing an acute knee via telehealth. So somebody's had an injury, they've called up for an appointment and said, what do I do? And I think there's sort of 3 main options you've got. The first one is to pick up the phone and call the emergency department and say, this guy needs to come in because he's had a bad knee injury. I think that's relatively rare, but you sort of think of that as the most significant option that you might need to do. The second option is just to refer. And so there's a number of specialists open, still practicing, including myself and Axis. So there are options and there is help available for patients where you think someone's had a significant knee injury, maybe doesn't need acute referral to the hospital, but needs assessment. And the third option, I think, is what most people are going to be calling through need, is a period of rehab and review. And I think if you think about these 3 boxes about what you're going to put a patient into when they're coming to see you for the first time via telehealth, I think it's helpful to have that conceptually. My limited experience so far of telehealth, I think we're all learning, and we're all sort of getting used to the idea that you can't physically put your hands on the patient's knee and get that feedback from them. And I think a couple of things to watch out for. One is that we should be reviewing early. So if you've seen a patient, you've assessed them with telehealth, made a plan with them, I think get them back sooner than you otherwise would, right? Because that's the temporal relationship of how symptoms change over time, and that someone perhaps couldn't weight bear very well initially, but then a couple of days later can. It just sort of, it gives you more information, and that early information I think is going to help you treat the patient better. And the second thing I think is refer earlier, right? Because again, if you're not sure about something, there's plenty of people sitting around now, even if it's not a formal referral, it's just an email. Hey, would you mind looking up at this case, or can you look at this x-ray and make sure there's nothing on it? I don't think anyone's going to mind doing that, and just that'll give you some reassurance, I think, that you're on the right path. The first thing I go over is a bit about the history. And one of the things that surprised me, having done now a few telehealth clinics, is actually how normal it is, how effective I am. Really now, when I'm making decisions about how to manage patient, most of it's on the history and the imaging, and then a few sort of key points on the physical exam, which you can often simulate pretty well over telehealth. And I think the history is where most of the money is when you're assessing an acute knee. And the things that you should be considering, firstly, is the mechanism. You know, what was the force that hit this knee? Did they fall from the top of the ladder, or did they just twist their knee when they were getting up from the floor? I mean, that gives you an idea of what potential damage they're going to have done, and that mechanism, I think, is really crucial. The second thing is, can they continue or play on? I put play on there. I think that's a really important aspect when you're assessing a knee, but probably most of the injuries you're going to be seeing over the next 4 weeks are not people playing games. But could they continue what they were doing? You know, did it get sore straight away, or did they know they'd done something bad and that they had to stop and evaluate, or did they try to continue but then couldn't because their knee stopped them? I think that sort of information is helpful. Again, the more severe the injury, the more they're going to not be able to continue whatever it was that they were doing. Was there immediate swelling? I think this is often sort of a bit overstated because it's often hard to tell, but if somebody's knee swelled up acutely, then obviously that's a hemarthrosis. And the things that bleed inside the knee are generally broken bone, broken ligaments such as an ACL, or a big meniscal injury or osteochondral fracture. So all sort of significant things that you're going to be wanting to get assessed perhaps more early and referring early if the patient swelled up immediately. Often patients are kind of a bit hard to get that information out of them, but if they said that it swelled up in the first 24 hours, or they noticed it was really swollen at the end of that day, I think that's a significant finding. And hearing a crack or a pop, you know, if somebody says that, then you really should be thinking they've done something significant, like a ligament breaking, ACL, kneecap dislocating, or a fracture. So all sort of these things that are trying to work out, is this patient someone I need to get help with early? For the examination, again, this is pretty hard over telehealth, but I think you can get a lot of the key points doing it. And the first is, can they weight bear? And again, if somebody's had a significant injury to their knee, broken a bone or ruptured a ligament, most of the time they're not going to be able to weight bear, and certainly not be able to do a single leg start. So, and you can examine that very effectively over telehealth. There's the second one, which I think is perhaps rare, but it's one that you do not want to miss, is an extensive mechanism rupture. So you need to be able to see, can they straightly graze? And that's really easy to do over telehealth. I mean, and I don't think you're going to be able to mess up that test if you get someone to split their leg out straight, lift it up, and if they can do that, you can reassure yourself that extensive mechanism is not ruptured. And that's perhaps the one injury that you do not want to delay more than a week or two of them getting to the appropriate care, because the longer you leave that, the harder it is. And delayed presentation of extensive mechanism rupture is still something I'll see 2 or 3 cases of every single year. And it's a really, really tough problem surgically to manage if that initial injury has been missed. Range of motion, you can examine that very effectively with telehealth, and you're looking for, again, things that might be acute and need referral earlier, like a locked knee. It's quite easy to pick that up from a telehealth consult. Just, can you straighten your knee out as far as you can, get them to put their foot on a chair and see, can they get the leg straight? And that gives you an idea of whether there's something or a restriction blocking it, and again, that should raise alarm bells. And effusion is a little bit harder, because certainly when I'm teaching registrars and medical students how to examine for an effusion, really it's a physical palpation. But you can perhaps not be quite so accurate with telehealth, but certainly if someone's got a big hemarthrosis, it's fairly easy to see. And this is actually a picture of a patient sent me last week. He's actually got an effusion because I operated on him 6 weeks or so ago. But you can sort of get an idea of somebody, you can see that on the screen on the video, or somebody takes a picture and sends it to you. You really want the other knee in the frame so that you can see and do that comparison. And I think a large effusion is actually quite easy to pick up if the patient's got the appropriate body habitus and perhaps not a really large BMI. Picking up an effusion that size is fairly easy when you can see both knees. For investigations, really, I think there's only one that we're doing in primary care for a knee injury, and that's an X-ray. I think the ultrasound of the knee has a pretty limited role anyway. I think it's probably overdone. And really, I think in the current environment of trying to ration what we do and where we send patients out, I don't think in the next 4 weeks sending people for a knee ultrasound is going to be particularly rewarding. But getting an X-ray, I think, is often necessary. And remember, primary care is an essential service. So if somebody's had a significant knee injury and they may potentially have a fracture, then they need an X-ray. And the private facilities are open to do that. And that's available, and that's the right thing to do if a patient's had a significant knee injury and you're assessing them by telehealth. A lot of the rules around who should get an X-ray and who shouldn't involve palpation. So most of you will know there's Ottawa ankle rules, there's also Ottawa knee rules, and a lot of the rules are around palpation. Obviously through a telehealth mechanism, you're not going to be able to pick those up, but I think some key points about getting an X-ray is firstly the mechanism of injury. If it's a significant force that's gone through the knee, I think it's a good idea to get an X-ray. If the patient can't wait there, either at the time of injury or a few days after, then I think again they should get an X-ray. And if they've got a large effusion suggestive of a hemarthrosis, they should also get an X-ray. One other one that you might include on that is loss of range of motion. So one of the Ottawa knee rules is that they can't bend their knee past 90 degrees, but I also think if they've lost a lot of extension, can't get it out, then these are all good reasons to get an X-ray, because it's also the one thing that if you don't get an X-ray up front with these sort of with patients with these sort of signs, and they turn out to have a fracture, they'll feel like they haven't been managed well. And I think what our goal with telehealth is actually to do a good job. And I truly believe that you can be effective. You just sort of have to change, I think, a bit the way about how you think about things. And as long as you, I think, follow these sort of guidelines, you can still do a good job. And getting an X-ray early on in the right patients, I think, is the appropriate thing to do. So if we think about specific conditions, common things happen commonly, and this isn't going to be an exhaustive list, but if you think of things that these 3 boxes that you might put patients in for certain conditions, the first is a fracture. So if somebody's fallen from the roof as they're trying to do some DIY during this 4-week shutdown and can't wait there, and they've got a big swollen knee, and it turns out they've got a distal femoral fracture, of course that needs to go to the emergency department. I think most of those big ones are probably going to go to the emergency department. I think they're unlikely to make their first call to a primary healthcare provider, but they may well do. And if they've got a significant fracture, then that's the appropriate thing to do. But we can order that X-ray and get it assessed via telehealth before making the decision to refer on. Quads tendon or patellar tendon rupture, again, that's got to go to the emergency department, because that's something we need to operate on in the first 2 weeks to get a good outcome. And I think those are the sort of 2 things when you're assessing someone with acute injury, just in the back of your mind, is there a possibility of these 2? Fracture is going to be the mechanism of injury and obviously the X-ray. Quads and patellar rupture is going to be unable to do the straight leg raise. A couple of other ones to think of, I think, is someone with a multi-ligament knee or dislocation. They might have, say, a normal X-ray, but a hugely swollen knee and a large mechanism of injury. That might be one you want to think about earlier. I think that's going to be very, very rare. Most of it is very high-energy trauma in New Zealand for knee dislocations, including motor vehicle accidents, and I think there's going to be a lot less of that in the next 4 weeks. And the other one I put in there is infection. It's rare to have an infective problem around the knee, but in New Zealand we have very, very high rates. And particularly in South Auckland, both septic arthritis and osteomyelitis in younger patients especially. So it's just something, again, to have in the back of your mind if a patient's presenting with, because they often will present with a history of minor trauma, or I knocked the knee against the wall and it's been getting more and more sore. But that history of worsening pain, especially if there's associated things like fevers, and particularly in pediatric patients or younger patients, just have that in the back of your mind, because and I think it's a good reason to review people early. If you think this isn't quite making sense, then maybe check on them again in a couple of days or the next day. If they're getting worse, then that's another reason they'll be to refer early. To referral to a tertiary specialist, but not to the ED, I think a locked knee is a good reason to do that. That is going to also need some fairly urgent surgery, but I think I'd much rather manage that in the current environment through telehealth, get a scan, and then bring the patient in to have the surgery for that, rather than getting them into the ED department now, trying to process them through that environment. They'll be in the waiting room for a long period, really at North Shore Hospital, in fact, all the DHBs across the country, what we're trying to do is minimise the people in the hospital and minimise the time that they're in there. Because if a patient comes to hospital a lot and they're going to be sitting around waiting for an MRI scan for a long period, and that's not the ideal for the patient, and nor is it ideal for the hospital system. So I think we can manage that sort of semi-acute, subacute problems more effectively in the community currently. That's also true for ACL and patella dislocation. So these are things that are probably going to need some more intensive investigation with an MRI scan, but I think we can manage that in the community currently in a more safe way than going through the hospital system.
Simon, can I just interrupt you there? There's a question that's come in asking about whether ACL reconstructions and other, say, non-emergency surgery is still happening over the next 4 to 8 weeks.
No is the answer. So yeah, on Tuesday I had a list last week with almost all ACLs, and I cancelled it. I think the hospital might have gone ahead, but we were at level 3 on that day. And true, I think it's hard to argue that an ACL is essential, or that the outcome of that patient is going to change in the next 4 weeks. So that's how we're viewing it at the moment, is that elective surgery is not appropriate to go ahead with at present. There will be situations where a patient could be harmed by that 4-week delay. I'm hoping it's 4 weeks. It might end up being longer, but if that delay is going to harm the patient, and that's probably true of a locked knee, that we might try and find space to do them earlier, because you've got a higher chance of being able to repair the meniscus if that's what's causing it, the displaced meniscus. But to be honest, it's a big grey area, right? We are all sort of battling with that about what's essential, what's not, and I think the consensus is amongst certainly the orthopaedic community is that the majority of what we do, a delay of 4 weeks is not going to cause clinical harm. So largely elective surgery in the orthopaedic world across Auckland and New Zealand is largely shut down. We're still doing acutes at the public hospital, but obviously that's sort of fractures, and even then we're trying to minimise the load of patients coming through, and we've increased our capacity so that acute patients needing surgery are coming in, getting done, and then going home, so that we're not having people sitting around waiting in the hospital.
I think I'm just going to interrupt you there. I think a point that is worth making, though, is that some of the delay to surgery has nothing to do with the surgery itself, and so I think that we still have the opportunity to work these patients up, to make the diagnosis, to make a radiologic diagnosis, and to submit an ARTP to ACC. So there is the opportunity to minimise morbidity and delay by getting on with these things early. So
yeah, I mean, I think that assessing the people and getting them investigated, that still needs to be done, because you need to triage these people, and a lot of them, to do that, you're going to need an MRI scan. So I think that part of our work has to go on, because if somebody does have a major knee injury, they need to know what it is. We need to because if it's a multi-ligament knee injury, then some of those will need surgery, and that will be harmful if it's delayed. So we did a multi-ligament knee injury this week for that exact reason. So the assessment and investigation of patients, I think, still needs to continue, and the management, once we know what we're dealing with, deciding what management's going to be is easier, and whether it needs to be done acutely or not.
And sorry, I'm going to interrupt again. It's your webinar, but I can't help myself. But there's the opportunity also to put people in braces, and while it is difficult to source those things, there are some systems that we've got in place to help do that, and we've got the supply chain for that. So we can still manage the morbidity. It just may not be the definitive treatment.
And then the final part of rehab and review, I put meniscal tear there. Most meniscal tears, knee strains, for want of a better word, and MCL injuries can be just treated with a period of rehab. It's still useful to know, right? And the MCL, I was sort of thinking as I put that up there, it's quite hard to assess the MCL via telehealth, right? You can't do a valgus stress test. So, I mean, I think if it's a significant knee injury with a lot of pain, even if it does turn out to be an MCL on an MRI scan, getting a brace and the appropriate things can still be done. So not all MCLs can be just sort of sat on. Some of the bigger injuries, which will usually go with inability to weight bear, more swelling, I think probably do need an earlier scan so they get the appropriate brace and the appropriate treatment. One there I've also put is fracture. So, because we're trying to minimise what goes to the emergency department, I think most sort of small knee fractures, and I'll show some examples of what they are I'd rather sort of see the X-ray and then make a call about whether that needs to go to public or whether we can manage more effectively in the community, at least initially. And there's quite a few small knee fractures that you'll get back from the report. And I personally, and I'm sure some of the other guys, will be very happy to get an X-ray. I get an email saying, "Oh, do you mind looking at this X-ray? This patient's been reported as this. Can you check? Is this something that we need to do something about acutely?" A common one or a well-known one is the Segond Fracture, which is avulsion of the anterolateral capsule, the anterolateral ligament from the tibia, which is pathognomonic of an ACL injury. So seeing that fractured is not something that needs to go straight to the emergency department. Rather, that goes along with an ACL injury, and I think that patient then needs referred through the community to be assessed, and then an MRI scan to work out if it's an isolated ACL or where there's associated injury. Other small fractures, this is an osteochondral fracture. It's quite a large one in this case, but the osteochondral fracture, you see there just superior to the patella, and this is from a patient who's had a first-time patella dislocation. That size of fragment is actually one that I would probably bring in acutely to go ahead and fix. But it's something that you see the small fracture, I would get an MRI in the community. I don't think that needs to go immediately to hospital in the current environment. Rather get the scan first, get them assessed, and then we work out if it's big enough to fix, and then bring them into hospital so they're coming in once they have their surgery done. And finally, little avulsion fractures like this. This is avulsion of the tip of the fibula. You'd think it would be the ACL, but actually where that attaches is the poplitealofibular ligament. It goes along with a posterolateral corner injury. But these small sort of avulsion fractures, when I look at that, it's not that this patient needs to come straight to hospital. It's more that, this patient's got a significant ligament injury, needs an MRI scan and assessment from there. So these sort of small fractures around the knee, I think they're fine just to be, they need fairly semi-urgent care, but they don't need to go straight to the emergency department. They can be referred through, and we can pick that up early on and manage at least the initial stage of investigation in the community. So Mark, should we go through a knee exam of...
Sure, I might just ask you another couple of questions. I've got a question here about tibial plateau fractures. So
yeah,
what would the management of those be at this time?
So it depends on the fracture, right? But most tibial plateau fractures would get operative treatment. If they're undisplaced, then we treat them in a brace. But if there's significant depression of the joint surface, then typically what we do is elevate that joint surface, pack some bone graft underneath it, and put a plate on. So that is something that probably does need to go through the emergency department. It's also one that doesn't need to be operated right that day. So I don't mind getting an X-ray saying just this need to come in straight away. But a tibial plateau fracture generally is something that you're going to be sending to the emergency department early on to get at least assessed for the option of surgery.
And then there's another comment about how we refer X-ray for clients currently. We'd normally hand them a written referral.
Oh no, I certainly don't think you do that. Well, it depends on your system, right? But if all you've got is a handwritten one, then hand it out, scan it, email it to the patient, and get them to call the radiology provider to do it that way. I think all across the healthcare community now, everyone's realising that we need to go paperless. Even prescriptions now, before prescriptions for pain relief, to getting those to the pharmacy, you had to have a physical copy or a fax prescription, but now they're accepting email prescriptions because everyone has email now, not faxes, right? So I think the system is now set up, and certainly radiology providers are ready to accept. I think even if you emailed a request, say, please can you do an X-ray with the patient details and ACC number, I think they would accept that as a referral and go ahead and do it. So I don't think you need to worry too much about having the right form or a physical copy for the patient.
Yeah, I think that there's another question or another point now says that for Mercy Radiology, you need to send and it gets individually assessed by a radiologist.
Yeah.
So that's not true at all of the practices. So I know that Auckland Radiology Group, and we can ask Steve in his webinar on Wednesday about their practice, but they certainly have changed their practice a lot, but they're accepting referrals. They're running a relatively normal service. It's just that the patient experience is quite different. They wait in their car, they're called in, there's more time between appointments. So it might be worth understanding what your radiology provider does. The other thing is that we've got very good access to imaging still, particularly at our North Shore clinic. So if you are struggling to get imaging, calling one of us or calling the clinic, we can certainly help facilitate that, or triage your patients and help them decide whether they need an X-ray.
Yeah, and I think if you had a referral not back for an X-ray, but you think that it's appropriate, then I think refer to a specialist, right? Because to one of us, because that argument is probably going to carry more weight. If the patient needs an X-ray, if they're going to be harmed, if this problem is not diagnosed, then they should get an X-ray. I think that's probably the question to ask. Is this X-ray going to change management or change the situation for the patient? Is the risk of going to get the X-ray justify the clinical outcome? And that's probably the question that we're all learning to answer.
And we're really trying to keep patients out of the ED as well, because we know that while it's relatively quiet there at the moment, it may not be in a week and it may not be in a month. So I think getting these practices up and running now is really important.
Yeah, absolutely. I mean, I think that's certainly at North Shore Hospital, the minimising patients coming through the ED department, both for their own patient safety and for the safety of the doctors going to assess them, I think is optimal. I think that's what we should be trying to do. So, Mark, should we cut out of share screen and go back to stop share, and I'll come back to you, and we'll try and just go through what you might be able to do in terms of physical exam on a patient.
Okay.
So I think the first thing to say when you're doing a telemed exam is that it's limited, right? You're not going to do your normal knee exam. It's just too hard. But I think you can get a lot of information from it in a very short space of time. And the first thing, and again, I'm going to weight this towards the acute knee, is getting the patient to stand up and watching that they can stand. And it gives you an idea of how much their trauma is. You can ask them to turn to the side and see that the patient's comfortable standing. Mark's these moving side to side and turning around. Again, that gets you to get a good look at the back of the knee. You get some idea of effusion here. If the patient's got a phone, they can point down. I find patients tend to always put the phone too close. What they need is to stand it back so you can see both knees at the same time, and when you're looking for swelling and discomfort. I think it's then useful if they can stand like this, like Mark can, is to ask them to move from side to side so they've got a single leg stance. So if a patient's had a major fracture or a major injury to their knee, they're very unlikely to be able to stand on one leg. And that's true of a patella dislocation, of an ACL injury. It's not common for people to be able to do that. Of course, not without exceptions, but I think if you're seeing someone like that, then probably that's comfortable standing on one leg. Your alarm bells are sort of dropping a little bit, if you like. I then think if the patient's comfortable like Mark is, then asking to squat can be helpful. Again, that gives you some information. They're doing a loaded squat now. It's a test for meniscus. It also gives you an idea of what their range of motion is. And again, you're not so much looking for them to measure the motion there, but just seeing that they can get down and get comfortable, and working out, is this a knee that I need to worry about, or is this something that we can be a bit more relaxed about? I guess, Mark, if you could come a little bit closer and we're sort of looking at your knees and side by side and trying to assess that effusion. Again, with someone with a phone, it's easy to do that, but if you can tilt down, look both knees, and you get a pretty good view there. Judging the not the most attractive knees in the world, Mark, but there's certainly no difference in size as well.
Yeah.
So you can. Oh, I've cut out there.
I think you did. Yeah. We're all
good. So with Mark looking down, can you put the screen down to just see both knees? Is asking the patient to point where they're sore. And it's just helpful, right? I mean, because you're always documenting if they've got medial pain, lateral pain, is it anterior knee pain or posterior? And it's pretty easy for patients to point and say, well, this is where it's sore, or is it more generalized? And even though you don't have the benefit of being able to palpate to confirm that that's tender in that region, I think you still get information from pointing the area of pain. Then while they're sitting in the chair now, so say we're looking at Mark's left knee as the injured one, I'd ask him to push down and try and make the knee as straight as he possibly can. Right, so here I want to know, can he get that knee straight? Does he have a fixed flexion contracture? So if you're thinking, is it an acute injury? Is this a locked knee? Is it a large hemarthrosis that's stopping him getting straight? But you want to be able to see there, is he able to get it? And you could also ask him to turn a little bit, so you're looking from the side to get an idea, is there a difference in the amount of extension between the affected knee and the other knee? I think that's good. And you can see he's able to get it all the way out straight. And then for that affected knee, we're going to ask them to the left side. Mark, if you just keep it straight, so putting it out while it's all the way out straight, keeping it straight, just lift the leg straight up in the air. Right? I think that's probably the one test that you do not want to miss, right? Because if someone comes back with a normal x-ray, but it's a big injury, if you don't do that test, then you'll miss the extensive mechanism rupture. It's still, as I said, it still happens commonly across New Zealand, as that extensive mechanism of rupture is missed. So if you remember one thing for today, on your telehealth, do a straight leg raise. Then I just ask the patient to bend up and see how far you can flex, and you can get it all the way up. Again, that's another test for a meniscus, and a generalized test for how inflamed, how sore, how swollen is this knee, how well can they bend it. And you can document this. It's got a range of motion of 0 to 90. You're still doing, I think, quite a reasonable knee exam over the telehealth. Certainly not what we're used to, and not as thorough or as thorough as we'd like, but I still think you get a lot of information from that brief search. There's some other tests as well that you could add into this. One's a patellar apprehension test. Mark's been doing this a bit in his clinic, so pushing out the side, and Mark then asking the patient to bend up while it's out and seeing if the patient's apprehensive. And if the meniscus test, the meniscus provocation test that you might do, most of them involve palpation, but there's one called the Thessaly test. Mark, if you stand up for me and just bend your knees down slightly, so it's done with the knee at about 30 degrees. If you just bend down slightly there, and then twist side to side. So a single leg twist side to side. And does the patient get pain on the medial lateral side? I don't think it's crucial to be able to diagnose that meniscal injury. If the patient's got some pain on the medial side of the knee, they can get the knee out fully straight, they're able to weight bear without a large effusion. I think it's fine just to tell that patient to get on a bike, give them some exercises and rehab them, and then reassess a week later. And if you think they're losing motion or something's wrong, you've got the opportunity then to refer again earlier. So, Mark, I've got we're up to sort of 30 minutes, so I'm conscious of time.
Yeah. So just a couple of comments there just about seeing different people. So if you go speaker view, you should be able to switch between different views. So you can have two people, you can have just Simon, you can have just me, you can choose. So. Okay.
Some people might have missed the exam focus there. I think we're videoing this out, Mark, so it'll be able to be up later.
That's right. So we'll post this. It'll probably go out on our own Facebook page, but we might share it with, I think, Physiotherapy New Zealand, and we'll put it anywhere you like, really.
Yeah.
I saw that there were some more questions, Simon, coming in just while I was moving myself around with a couple of different comments. So one was, I get a partner to hold the phone if possible to get the distance right. So the only thing is to just make sure you've got consent from the patient to have the other person do that. So, and yeah, it was my settings. A self-palpation from Dylan Smith. So I don't know. Do you find asking a patient to palpate their own knee?
Yeah, I was talking with Dan Exeter about that. He's been getting people to do that and see if they'll tender. I think it's hard to articulate where you want them to palpate. You know, like for me, are they tender over the MCL origin on the medial epicondyle, or are they tender over the joint line? And trying to get a patient to distinguish between those points, I think, is difficult. So I haven't been going through the palpations. I haven't found it quite so rewarding. But I think there's no harm, and if you've got a patient who's informed and you can get them to try and isolate and say you saw there, press there, then absolutely. I mean, you're going to tailor these examinations to the clinical presentation and what the patient the symptoms are.
For what it's worth, I found that quite useful. So I think if you start with asking them to find a landmark that's easy to palpate, like just next to the tibial, the patellar tendon, I think that most patients can find the bony parts of their knee. Even if they can't, you can generally tell roughly where they are. So me personally, I think that's been quite useful, but it is about mucking around and trying to decide what is the system that works best for you.
Yeah.
Another question, Simon, would you try to make the patient replicate some physical tests like a valgus stress?
No, I don't know what your experience has been at, Mark. I mean, I think it's a little bit dangerous, right? Because you'd either get them to load it themselves or get someone else to do it. And I think that it's such a subjective feel when you're learning to do that. You just do it over and over again. And the amount of force to apply and to judge what degree of laxity is there, you really need to assess the other side. So I think your assessment of the collateral ligaments is something that is probably not done well through telehealth. And if somebody's got a big MCL injury that needs a brace, distinguish between, say, a minor MCL injury and a significant MCL injury, that is hard. And I think you probably have to go on indirect measures like the degree of swelling, ability to weight bear, and the mechanism of injury, and probably refer that patient early if you think they've had a major MCL injury to get a scan early, and decide whether a brace is needed based on that.
Yeah, I think that's exactly right. That's what I've found as well. And I think in my experience with telehealth and acute knee injuries thus far, I think the scan does become more important.
Yeah.
So if you have a patient who has a big swollen knee, you know that something bad has happened. I think you're doing already a compromised assessment via telehealth anyway. So I think that if you think that something is bad might be going on, I'm far more likely to then arrange some further imaging. So I think it's about finding what you're comfortable with, but big swollen knee, I wouldn't be mucking around trying to replicate ligament tests. I'd be trying to then do a more definitive investigation.
Yeah, and I think that's appropriate, right? Because if someone has had a major knee injury, then we need to manage it appropriately. And if that means a brace, then they need to be diagnosed and treated early.
Another question, what about the value of a self-administered swipe test for something less acute?
So, yeah, I mean, I guess what I'm thinking when I'm looking at these through telehealth is broad strokes, and distinguish between, say, a minor effusion that might go along with a meniscal tear versus a large hemarthrosis. And that's what you might pick up with a swipe test, the grade of effusion, how much is there. I guess if you've got a compliant patient or a patient who's good and can understand the instructions, you could administer that. But I think probably not missing the big, hugely swollen knee is what you want to pick up from your telehealth exam.
Another question, with the straight leg raise, if the patient can't straighten fully due to pain, but can lift their leg with their knee still in 20 degrees of knee flexion, is that enough of a test for the extensor mechanism?
Yes, is the answer, yeah. So quite commonly, someone with a patellar dislocation or a ACL injury won't be able to get their knee fully straight because of the big hemarthrosis. But it's a difference between an extensor lag and a fixed flexion contracture. So if somebody's got an extensor mechanism problem, then they won't be able to get the heel off the ground in any position at 20 degrees fixed flexion or at all. If somebody's just got a large amount of swelling or even a locked knee that's mechanically meaning they can't get the knee out straight, only getting to 10 degrees, they'll still be able to lift the heel off the ground. Some people say after patellar dislocation won't be able to do a straight leg raise because of pain. It'll be too sore to do it. But again, that should be ringing alarm bells. And you might suspect, this is just a pain problem, or I'm not so worried about this because of the mechanism. But that might mean that you couldn't straight leg raise, but I'm going to check you again in a couple of days to see if you can. And if they still can't do it, then that patient probably needs to be assessed.
Yeah. There's a question here from Tim asking what's our capacity for urgent patients at the moment. And we have at least one full clinic a day that is available for acute patients. So the way that we feel that would be the most helpful over the next few months is by keeping patients out of the ED. And so we really would encourage you to refer anyone in that you think might need imaging. If you think they're struggling with pain, if they need a work certificate, we're really angling our clinic or kind of tailoring part of our clinical life for those acute patients. So there may be patients that you'd never normally refer to us because you can sort them out by referring them to a pharmacy or to a GP. We're really well set up to help those patients. So feel free to send them and we should be able to get them, if not the same day, the next day.
Yeah, even getting things like prescriptions now, I think is tough for people not wanting to go to the GP or patients with places where acute care is going on for the risk of transmission. So getting some anti-inflammatory, I think that's something that can be helped with.
Sort of on the same theme as before, would you try and instruct patients to do ACL tests like Lachman's tests? And what value are isometric tests for muscle strength?
I think for the Lachman's, no. I mean, I actually think the Lachman is in clinical practice is not that useful. I use it when I'm assessing, degree of instability in a knee. But in somebody who's had an acute knee injury, the Lachman's very difficult to interpret. you might have more suspicion in someone loose, but the value of the Lachman to me is in someone with a delayed injury, something that's been missed, and you're trying to pick up how unstable their knee is, or certainly when I'm in the operating room examining someone you're about to do it on, how unstable is this? Do I need to add in an anterolateral ligament to try and stabilize any further? But I don't think a Lachman's hard for anyone to do, let alone a patient. So I don't think that should be part of your telehealth consult.
And how about just finally testing muscle strength at home?
Yeah, I think for my standard sort of knee exam, when you're assessing a new acute knee, mostly it's pain inhibition that's leading to the weakness. So someone can got power in their quads because of either pain inhibition or disuse. If you've got more chronic condition, I think assessing that is reasonable, and you can assess that whatever muscle you're trying to test, the quads, the number of whether they can do a single leg squat, or the number of repetitions. You test hamstring strength. I think you adapt what the information you're trying to get out of the consultation with telehealth to what you're able to do.
Cool. Another couple of things about how you logistically refer patients to us. So we're just running a kind of quote unquote normal operation. So if you're referring patients, absolutely the same emails and same phone numbers. They're all diverted through to our admin staff at home. The other thing is just on the email to register for this webinar and the other webinars is my email address. So if you're having trouble getting patients in, if you're having trouble finding analgesics or anything like that, just flick me an email and I can either help myself or I can make sure that the admin team gets in touch with you. So definitely through normal channels for us. I'll just check. I've got two little things here going. So cool. Oh, good news, Simon. Your presentation's been quite good.
I might have
high praise from Pip Sale. It's great.
It might be a planted comment.
So looks like there might this last chance for a few questions here. The other thing is we are going to run some more of these webinars. They seem to have been quite popular, and as I said, it's a very strange time, and if for no other reason, it's just good to talk to people and have a degree of normality of having me and Simon in your living room on a Tuesday night is normal, Monday night. But look, if there's anything else that you'd like us to talk about, or if there's anything else you'd like us to kind of show next time, make sure you let us know. So as I said, we've got Dan talking about medication and analgesics tomorrow. Steve Wood from Auckland Radiology Group talking about radiology on Wednesday. On Thursday, we have Simon Grigger talking about marketing. And then a wrap up of the week with me if people are interested on Friday. But we thought we might do one or two again next week, depending on how these have all gone. So a couple of other things, not so random, but things like scaphoid fractures, do we still go through GPs or refer for you guys? So I'm going to take that one because you're the knee surgeon. I personally, the last place I want to be is in my GP's waiting room. My wife is a GP. The last place she wants to be is in her GP practice. And so I think there's a real opportunity for us to help minimize that throughput. So patients, for example, with a scaphoid fracture, patients that you might normally send to your GP, by all means send them there, but we are really well set up to kind of manage that patient remotely. And the scaphoid's a great example where I just don't think they potentially are ever going to need to go near the ED or the GP clinic. So
I speak from a consultant at North Shore Hospital. I think we would much rather that sort of subacute trauma that may still need an operation gets assessed in the community, and then we're getting an email with this patient's got this, they've had this X-ray, this and this scan, this is what we've seen, and then we can make the call about whether to bring that patient into hospital or not to get scanned. Because the reality is, over the next few weeks, going to hospital is far riskier than getting managed in the community, at least initially.
Good. So just another couple. So how long do you think a good assessment consult would take via telehealth?
Yeah, I can speak. I don't know what you found, Mark, but my consultations are exactly the same length. I find that they're Some patients you end up talking longer, and they go just like in real consultations, and some people seem to be quicker. But currently in my clinics, I'm running exactly the same time frames as before, and I haven't changed. I don't know what you found, Mark.
Exactly the same. So I feel like there are some occasions where it's a little bit faster. So some patients perhaps don't ask quite as many questions. Some patients ask a lot more. So I'd say it swings and roundabouts.
Yeah, I find I tend to run closer to time in the tele clinic because I get nervous when people are sitting in the virtual waiting room. I feel like when they're told to log in on that time, you feel like you should meet it.
Another question. So what would your advice be when having to treat via telephone call and not having access to the internet if you feel they need to be assessed properly?
So if you're assessing them, you mean from?
Yeah, I think there are maybe two parts to the question. One is how do you think the phone is relative to this kind of telehealth platform? And the second is what do you do if you think actually they need to be seen by someone physically?
I mean, if people need to be seen, if there's a reason to, then they will, right? Like I think we're doctors, and if someone has to be assessed properly, and that goes for any condition that they're going to have, any medical problem, they're going to need to be seen, and whether that's in our clinic or in the hospital, then that can be arranged. I think the phone for an initial acute patient assessment is hard. I think doing a new patient assessment by phone is very difficult. All you really can do is just give some broad speaking advice about where to direct them. Follow-ups are different. I think if you know someone, you've seen them before and assessed them and have a good idea of what's going on, I think you can be quite effective over the telephone. But I think if you're seeing someone for the first time, a video link is really helpful. You need some idea of the physical situation, and even though it's not a perfect exam, I think the video telehealth exam still gives you a lot of information that's helpful.
There are two questions about using non-steroidals in the COVID environment. So that's a large part of what Dan wants to talk about tomorrow. So I think there's enough evidence to be quite careful with most analgesics, but I think if you think the patient needs analgesics, then I think you could still make an argument to prescribe them. I think my main comment is, as a physiotherapist who's not prescribing medications, do you want to be the one counselling that patient or making those decisions for them? And I think that we're probably in a much better position to be able to do that, and we can do that quite quickly. So for the patient, I think that probably is better for them, and it's not really requiring them to sacrifice anything, have big times in waiting rooms and things like that. And I just see us all working in a much more collaborative and different, slightly strange, but ultimately I think good way. So that's kind of how I see that. When you guys are seeing a patient who needs a major knee brace, are you able to get these delivered to the patient at the moment? The answer is yep, no problem. So if you're looking for a brace, we can help arrange that. So just again, send us an email. And then if we suspect a patella tendon rupture, would a referral to ED or U be better?
I think either, right? If you go to the ED, basically you're picking up the phone to be asked to put through to the orthopaedic registrar, and that might involve a long wait, so, as it says it sometimes does, but you can pick up the phone always and do that. If it came through to us or to me, I would look and probably organise some imaging and then get into the hospital as well. So I think either way is fine as long as it happens soon. So that's something you need to be doing within a day or two or the same day, not leaving it a week or two.
Cool. So look, I think that might be all the questions and comments. Let me just quickly check. Are you providing a record of this presentation? Yes, so that will go out on our social media channels probably tomorrow. And I think we will also send it out through Physiotherapy New Zealand. Not totally sure about that. So look, again, I hope that's been useful. We're really keen to, I personally am enjoying talking to someone other than my kids. So even though I'm sort of kind of talking to myself, but hopefully that's been good for you guys too. Anything else from you, Simon?
No, that's all. Thanks everyone for tuning in. I hope everyone's staying safe. Yeah, good luck through this time.
Cool. And yeah, look out for Dan Exeter tomorrow at 8 o'clock, and a little bit more about non-steroidals, talking about paracetamol, talking about other analgesic options, and also talking about corticosteroid injections. There may be one last question. In acute, subacute knee injuries, it's very common to find hamstring spasms that make a proper assessment of the knee. Any recommendation or trick to relax the knee?
Yeah, I don't know. I find that too, actually. I think that's a good observation. Doing it on more than one occasion probably is a good, and maybe asking on the second time if it takes some anti-inflammatories beforehand, if you really think that's limiting them. It's what you can do on a telehealth exam is tough anyway. And if you're worried that that's limiting it, I guess it's referring earlier and getting advice earlier. If you're worried that you're missing something because you're not examining properly, then referring earlier will sort of shift that responsibility and get another set of eyes on the problem.
And the only other thing I would add to that is just making sure that you're trying to get the patient in as comfortable a position as you can. So in this sort of environment, I've got my leg propped up on my bar stool, so maybe making some time to get the patient to find a more comfortable position might be helpful, but it is difficult. So look, I think we'll wrap it up there. Thanks very much for your participation. It's been great to have some questions actually. So for those of you that do participate in the other ones, maybe come prepared to ask some questions either down through the Q&A box down the bottom or through the chat box down the bottom. So thanks very much for your time, Simon. It was great. And thank you for joining us, and look forward to working with you closely over the next month or so.
Thanks, everyone. Have a good evening.
Bye.
Cheers.